This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare, and we're going to talk about a subject today dealing with opioids and opioid addiction. We're delighted that we've got with us Dr. Glenn Hardesty. Glenn is trained as an emergency room physician, but he also has an executive role with Texas Health Resources in their medical affairs division. Glenn, thank you for being with us.
My pleasure, Steve. Thank you for having me.
You know, opioids is what we've all heard a lot about, and we hear about Ohio, and we hear about Appalachia, and we hear about the opioid problem. Here at the Hospital Council Foundation, we did do a community health needs assessment over a 16-county area looking at substance misuse. And alcohol and meth outranked opioids. Now, I'm not downplaying opioids. Clearly, opioids was something that was an issue. But is opioid use geographic or regional, or what are your thoughts on that?
Well, there is some geographic propensity for there to be higher addiction on the East Coast. That's what some of the data will show. I would argue that the data locally is underreported. When we looked internally at Texas Health at our data, it really didn't show the problems that we were experiencing in the emergency department. And as an emergency physician, when somebody comes in unconscious or with a diminished level of consciousness, we don't always know what caused that level of consciousness or decreased level of consciousness. And oftentimes they just return back to a normal state and we never figure out exactly what the causative agent was. Knowing that, opioids likely played a role in that. Now, to that, I can think of 3 cases that still haunt me today of young women being struck down in the prime of life because of an opioid addiction. And the story was the same every time. She was a great girl, got mixed up with the wrong crowd about 6 months ago, and this is where we are today. And so I would see opioid addiction and the opioid issues almost as frequently as we would see violence in the emergency department.
Wow. I think we're trained, as we should be, to always listen to the provider and try, if we're a patient, to follow instructions. Great example, antibiotics. When you start feeling better, don't quit taking your antibiotics. You should take the antibiotics as directed by the provider. Have we, over the years, maybe had prescription opioids and maybe people continued to take them when they really didn't have the level of pain? Or what are your thoughts on that?
Well, I think it's multifactorial. I think that there was an edict to address pain and to treat pain. And that reflexively came out as, well, we'll just give them more pain medication. We were told that we were under-treating pain. And for years, I know I've talked about and been reluctant to prescribe to the level that was being pushed out on providers. And it wasn't until opioid addiction and opioids were declared a national health emergency that tide really changed almost overnight. That it went from prescribe till they don't hurt to now think about your prescribing, and even the state stepping in and limiting the amount of time that you can prescribe those medications.
I've worked in hospitals most of my life. I've been here at the Hospital Council for a few years, and I really enjoy my role. But I remember, and I'm not going to get too much into the weeds for our listeners because I know they don't all understand this, but hospitals do get graded, and we had HCAP scores, et cetera, which address some of the things you talked about, the patient experience, and did they experience pain? And I think there was a time, especially when providers looked at how do I minimize pain in the patients. And as a result, maybe there were times that we probably did everything we could to minimize pain, but we may have used opioids more than we should have.
I think that's very well stated. And in fact, it was something that we had to do. We felt that we had to do it. And if people complained of pain, that was a shortfall on the part of the practitioner. Now, not to underscore that pharma did develop medications and did push some of this out with, junk science. And if you look back to the studies that they quote, one of them was from 1970, before I was born. And I think about what other medical practice do we do today that was in place that long ago, and especially for how frequent we use these medications.
Right. So let me ask you this. There are people that do need opioids, and the physicians and the providers prescribe them as they should. But to our listeners, if they have opioids and they have them at home, and there are other people that could get into the medicine cabinet, et cetera, do you have any thoughts about, if you do have opioids for a very legitimate reason, how do you protect and keep them secure?
Thank you, Steve. I have two thoughts. One is absolutely to have a safe or lockbox so that they're secured. It's well known that 72% of new addicts for opioids get the medication from somebody else's medicine cabinet. So they either get it from a friend's, parents, grandparents, wherever they get it from. It's not prescribed to them, but they obtain it by going into somebody else's medicine cabinet. Secondly, if you have opioid medications that you're not using, remove them from the environment. DEA has drug take-back days. There are also disposal sites that are on Google Maps that you can go to and find where's the closest place I can go drop off my opioids, and that they're destroyed so they don't fall into the inappropriate hands.
If you have a family member or a friend that you really suspect and can tell by their actions are probably using opioids inappropriately, what do you recommend?
Well, I recommend to talk to them first, and to understand this is a disease. As a clinician and as a longtime ER doctor, it was hard for me to make the transition from it's a character weakness to a disease state. And remember, this is a disease. I can prescribe narcotics to 100 patients. 5 get addicted, 2 get really addicted, and I can't accurately predict which ones those are. So I have to change my prescribing habits to limit the number of people that I expose that medication to.
We're going to continue this very important conversation on the opioid crisis in America and in North Texas. What are your options if you're facing surgery or have chronic pain and this form of relief is no longer available to you? Dr. Glenn Hardesty from Texas Health Resources back with more on how hospitals are grappling with this difficult issue. Also, a reminder to catch our podcast on all the major podcast players. Just search the human side of healthcare.
We're now going to break for traffic and weather together on the H News Radio 1080 KRLD.
Healthcare is changing rapidly. The national debate is escalating and will be a big focus of this year's presidential campaign. We're here to help unpack these important topics, along with over 90 member hospitals across North Texas, who are proud to bring you the human side of healthcare, with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
This is Steve Love. Welcome back to the human side of healthcare, and we're going to continue our conversation with Dr. Glenn Hardesty. And this is a fascinating conversation, and I hope the listeners understand that we're trying to educate and also improve the health of the community. Dr. Hardesty, in the previous segment, we talked about opioids, opioid addiction. And, I think one of the best things you said, we realize addiction is a disease. And if people do have an addiction or they have substance misuse, we want them to seek treatment. We want to make sure that the stigma of seeking help is not there and that they do the best they can to treat this illness. Now, with that said, on the provider side, And when I say provider to our listeners, I'm referring to physicians, I'm referring to hospitals, I'm referring to the people that actually provide treatment to you. Opioid addiction, hospitals have been criticized, physicians have been criticized for overuse or overprescribing them in the past, tied back to let's not have pain. How are things changing today to address that opioid use?
Well, the tide has changed around the attitudes towards opioids, in so much that there's some protection for the physicians to say, we're not going to do this because. And it's been just monumental in being able to have conversations with patients to say, I think there is a problem here, because the entire way we address it, has changed. And you can really think of how we're addressing it as a healthcare system at Texas Health is around, four main points. One is education and awareness. What are the prescribing standards? What is the problem? How serious is the problem? And have I contributed to the problem, or what can I do to reduce the problem? And we do lectures to our medical staff on those very topics. Also, nursing education needs to follow suit, and we're developing nursing education to reset what is the standard across nursing, knowing that for a long time, chronic opioid use was not considered dangerous. Well, we know that to be so far from the truth today that we really have to change culture in both the physicians and nursing. Also, we need to get out in the media and advocate the dangers of opioids and the importance of their safe use.
A couple of years ago, I had to go to the hospital and I had major surgery. And one of the things the hospital gave me pre-surgery was there is going to be pain associated with your surgery. We're going to do everything we can to keep you comfortable, but there is pain. What are some of the things you see hospitals doing to educate patients that there could be pain associated with the procedure? And also, what are some of the alternative type medications that could be used rather than opioids?
Certainly being, I think, more transparent with patients on what to expect. I think we weren't doing patients a service by saying that we're going to eliminate your pain. We need to be more open and honest and say we're going to mitigate your pain to the safest extent possible. And I think messaging, as you said, there will be some pain associated with that. We can't safely take you down to a pain score of 0 and still maintain your breathing and maintain your oxygenation. So I think educating patients of the dangers and the care circle is important, because people don't want to see their loved ones suffer. I think also our prescribing standards and how we have changed our prescribing standards, going from starting low and go slow, not prescribing for more than 5 to 7 days, and keeping the morphine milliequivalents, which is a way for us to gauge the various types of pain medications with a single unit where we can tell where the danger zone is, and using cutoffs for levels and prescribing levels for those pain medications.
For our listeners, especially if they're going to have an upcoming procedure or at any hospital, because we serve all the hospitals here in North Texas, are there any recommended questions that you would tell them they should ask their provider?
I think following on your previous question around, are there other things that we can do besides give you pain medications? Certainly multimodality pain control, pain blocks. In fact, 2 of our hospitals for elderly patients now do hip blocks for hip fractures in the emergency department, so that we don't have the side effects and we get them out of the hospital quicker when we use regional anesthesia, as opposed to using a more broad-based opioid, which has the systemic effects and the increased length of stay and increased complication rate.
So in your role in an emergency room, and patients come in many times that are unconscious, and you may not know why, and you have to find out. What would you say of the people that have used potentially opioids inappropriately? Is there an age group they fall into, or is it kind of all over the board?
It's funny. This question comes up quite a bit, and it is really kind of all over the page. My experience has been that the tragedies tend to be younger patients, and the complications tend to be older patients, meaning that a young person that overdoses, we find them, an hour or 2 hours too late. Whereas a older person, they might have chronic illness and they're just a little off according to the family, and they bring them in, or they're not as responsive as they usually are because they may have some tolerance to the medication. But there's not any hard, fast rules to that. That's just an observation over the years.
Another thing, and you get into healthcare outcomes, you get into statistics, et cetera. I was actually on the Center for Disease Control website the other day and looking at some of the leading causes of death. And there's been a big increase in accidents. And, I was thinking in terms of automobile accidents, et cetera, but it's accidental overdoses from opioids. Do you have any comments on that?
Well, I have a lot of comments on that particular topic. It was in 2015 that unintentional overdose, primarily that of opioids, became the leading cause of injury-related death in the United States, more than motor vehicle accidents, more than homicides by firearm, more than drownings, more than falls. Now, what I think's not illustrated on that table that I think you're referencing is the proximate cause of opioids on motor vehicle accidents. Do we think that somebody had a motor vehicle accident because they had a few too many opioids? I think that's very possible. Firearms and drugs and guns, does that go together? I think they do. So I think if we look at it in those terms, the impact on opioids in relation to mortality is much higher than we initially thought. And in fact, there's some thinking that's beginning to talk about that. Now, when we talk about leading causes of death, I believe injury is number 4, so it's not the leading cause of death. I mean, cardiovascular and lung are up there, but injury-related death is perhaps the most preventable of all of those, and thus it is the leading cause of preventable related death.
As we look at opioids and we look at what we're facing in this country, and I know the CDC is concerned, I know the FDA is concerned, I know providers, I know emergency room doctors, hospitals are all concerned. As our listeners are hearing as we discuss this, to conclude this segment, are there any final thoughts or words you would tell our listeners, either one about opioid use or things they should do and be aware of?
Yeah, I would say remember that there will be some pain associated with procedures. Use non-narcotics up to the point where you can't tolerate the pain before we move into narcotics. Don't go straight into taking an opioid the first time you have a little twinge of pain. Secondly, make sure to get rid of those medications in your house once you no longer need them. Statistically, they will end up in the wrong hands and lead to another person becoming addicted and continue the cycle. No one's ever died from pain, but opioids are the leading cause of injury-related death in the United States. And I think it's time we take a look at what we're doing and change our practices.
We want to thank you, Dr. Hardesty, for being on the human side of healthcare. And I know this is a difficult subject, and I know it has caused great pain and anguish in this country. But for our listeners, we hope this segment has helped educate you, and hopefully, by all working together, we can improve the health of our community.
And when we come back, we're heading over to Parkland to talk about diabetes foot care, one of the key areas of prevention and treatment for those dealing with diabetes. That's next on 1080 KRLD, radio.com, and podcasts everywhere on your favorite podcast player.
This is the human side of healthcare on 1080 KRLD and the radio.com app. where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome to the human side of healthcare. We're going to talk with Kellie Rodriguez, who is the Director of Global Diabetes at Parkland Health and Hospital System, and we're going to talk about healthy feet. So, Kellie, let me just start out. What is the real purpose of a Healthy Feet initiative?
Our Healthy Feet initiative was developed at Parkland with support of UT Southwestern faculty to really sort of efficiently and effectively identify foot risk in the person with diabetes to deliver the right care to the right person at the right time. It's really a prevention model aimed to sort of minimize the development of really difficult, complex diabetes-related foot complications, including avoidable ulcer development and amputation, which clearly has significant personal and societal impact.
So if I'm a listener and had diabetes, for example, why is it so important that as a patient, I receive timely foot evaluations and, if needed, treatment?
It's really about preventing costly foot complications. And by costly, I don't just mean monetarily, but I mean costly in terms of the impact that it has on the quality of life, not only for the individual, but for their family as well, and the health system and broader community. So undertaking at least sort of annual foot risk screening and self-foot examinations are really critical to the early identification of at-risk feet and the initiation of timely intervention.
So my next question is kind of a two-part question, Kellie. If you're a diabetic, having diabetes, question one, does that put them at additional risk for foot wound? And number two, if so, how many patients does Parkland treat that puts them at risk for foot wound?
Certainly, yes, diabetes does put people at increased risk for foot problems, primarily because of issues with blood flow down to the feet, as well as with sometimes a loss of feeling to the foot. So it can be amazing to think that someone could be walking with some sort of stone or object in their shoe and not feel it. But that can really happen for people with diabetes. It's a term called neuropathy or nerve damage, and it inhibits people from being able to sense pain sometimes. And pain, as much as we don't like pain is a good thing for us to be able to feel because it lets us know whether we have a problem. And for many people, it's what instigates treatment or evaluation. So diabetes can be a significant issue in terms of foot complications. At Parkland, we have over 35,000 active patients with diabetes, and it is estimated from our specialists that about 20% of those people, or around 7,000 people, would be at risk for complications such as foot wounds and amputation, which is why a preventive model and a preventive mindset for foot care is so important.
And so, when you think in terms of diabetes and seeing the professional that's treating you and the provider, it goes without saying that foot care specialists need to be involved in the evaluation and treatment, at least in the higher risk patients with diabetes. Would you agree with that?
Yes, absolutely. Foot specialists such as podiatrists are highly skilled in the assessment and treatment of complex foot conditions. Factors such as poor blood supply and damaged nerve vessels that we talked about may result in people not being aware of their high-risk feet due to a lack of pain or feeling in the affected area. And so early identification of the at-risk foot by specialists and foot specialists and best practice treatment is critical to successful outcomes.
You've talked a little bit about the foot specialists and some of the work they do. Are there other services offered from these types of providers on the foot care teams?
Yeah, so we have community podiatry services that includes podiatrists, registered nurses, and senior medical assistants. And those services may address more of your basic needs, such as nail and callus treatment, through to more complex foot deformities, such as bunions and hammer toes and fractures. We have 3 community podiatry teams within the Parkland system. There's also a foot wound clinic that includes specialist podiatrists, advanced practice providers and nurses, as well as important clinicians that help provide orthotics or insoles to make it easier for people to be able to walk in a way that is in a manner that commensurate with appropriate dynamics. And so we really find that with those individuals, they're doing more surgical interventions in the hospital, including, unfortunately, amputation or addressing complex foot ulcers. So just like diabetes in many ways, foot care is also sort of a stratified piece where we have high-risk feet and lower-risk feet. But all that we want to be able to do is really focus on the preventive mindset, because that's our goal. Our goal is not to treat. Our goal is to prevent.
So if we've got a listener out there who feels that they are, or even have been previously identified as high risk for serious foot complications, what would be their next step?
Certainly. So we would really want those patients to be able to be a part of a care team. And as I mentioned, those that have active ulcers or Charcot foot or some of those high-risk conditions really need active involvement, sometimes every 2 to 3 weeks, just to be looking at what's going on with their foot and providing the appropriate treatment. In many situations, especially in an active ulcer, treatment may need to be weekly in terms of outpatient care. So it's really important for individuals to be a part of a care team, to be able to be proactive and address the immediate need, as well as learn about important preventive models that are needed, which may include looking at footwear and orthotics and insoles, so that people are walking in a manner that doesn't put pressure on unusual places of the foot.
So for our listeners that may have been diagnosed with diabetes or have family and friends that they know have been diagnosed with diabetes, from your perspective, Kellie, what would be precautions that you would recommend these people to take to ensure that they maintain foot health and avoid complications? What would be some of those things you'd recommend?
The first thing is to take a preventive mindset. I think that's the challenge with chronic disease and healthcare. We are often attuned that when we have an illness or have a problem, that's when we seek care. In diabetes, we have to take the very opposite approach and prevent problems from occurring. So it's a very preventive mindset. And so when it comes to foot care, it really begins with like daily foot inspection to look for signs of risk, such as redness, swelling, cuts, scratches, and then to seek care if any of those things are occurring. It includes daily foot hygiene, proper fitting footwear is also important, and it really, as I mentioned, is important for maintaining preventive health checks and not waiting for that problem to arise before seeking care. And of course, there's the clinical picture too. It's about optimizing blood sugar control, blood pressure, cholesterol results, and of course, definitely no smoking, which is a real risk for vascular problems as well.
You know, chronic illness adds so much to the cost of health care. And as you know, there's a lot of discussion today about the high cost of health care. Do you have an estimate or a range of the cost of treating diabetes for an average patient on an annual basis?
I've seen anything up to $10,000 or more a year in terms of just annual costs for people with diabetes. I think it can depend on the status. I don't know what the usual patient is anymore. Diabetes is changing. We have pediatrics developing type 2 diabetes, adults developing type 1 diabetes. It's a much more complex disease process, and so we see so much diversity in our patient pool that we see those that are very high risk and those that are low risk, and it's hard to know what is normal in the middle in terms of diabetes outcomes.
Right. And, you know, I guess another point, and I know we talked specifically about feet today, and we've talked a little bit about nutrition, but physical activity is important too. And what is your recommendation on people with diabetes in trying to get physical activity, especially with type 2 diabetes?
Yes, physical activity is really important. And I mean, the general recommendations for activity wherever possible is to do 150 minutes per week. But that's not always easy, and it really depends on other complicating factors. So with diabetes, people with diabetes can have issues with eye disease, vascular problems, foot anomalies, heart initiatives and heart problems. And so it really depends on their clinical picture as to what type of exercise they should be doing, and importantly, how much they should be exerting themselves with exercise. And so we always recommend with exercise, other than general walking, but to really talk to your healthcare team about your current medical state and what might be the most appropriate exercises to do. Is it more aerobic exercise, such as walking or swimming, or is it more anaerobic exercises where you could do things with light weights? Often the combination is best, but it really depends on the clinical picture.
Do you see any type of trend or outcome where you actually reverse the diabetes?
I think there's a real focus on diabetes prevention, and as there should be. As we said before, diabetes is very much about prevention over treatment. And we've identified through research that if you do really intensive physical activity and nutrition impact, you can have the chance, a 50% chance of reversing the aspect of diabetes for type 2 diabetes. The challenge comes, I think, with maintenance, as well as the fact that diabetes tends to be a progressive disease. And so I don't know that it ever truly goes away. We might be able to get better blood glucose control, but it's certainly something that requires ongoing monitoring and management. And we're generally finding that as people are being diagnosed earlier in life with type 2 diabetes, the challenge comes with a lifelong aspect of diabetes management that as a progressive disease, people aren't able to sustain lifestyle modification purely, and even sometimes oral management. It often requires injectables. So it's a very difficult disease state.
There is a longer, uncut version of this interview with Kellie and Steve on the Human Side of Healthcare podcast as a bonus track. That's available on all the major podcast sites. Just search the Human Side of Healthcare. Now, coming up next, and talk about knowing somebody who knows somebody. Are you or do you know someone facing cancer? Well, there's a free community resource in North Texas called the Cancer Support Community. It's a nonprofit with clubhouses in 3 locations around the Metroplex to help people and families dealing with their cancer diagnosis. Stephen Love and Mirchelle Lewis next, talking about cancer support on the Human Side of Healthcare.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environment. This is the Human Side of Healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
Today we're going to talk about a topic that impacts so many people in North Texas, and that's when you have cancer. And you come to the hospitals, you receive your treatment, and then hopefully you're on the road to recovery and you go back to your homes and to your communities. And the hospitals are delighted that there are support groups that work within the community. And one of those support groups is the Cancer Support Community for North Texas. We're delighted to have with us today Mirchelle Lewis. She's the CEO of that organization. Thank you for being with us.
Delighted to be here. Thank you for having me.
For our listeners that may or may not know about your organization, and I know you're in Fort Worth, I know you're in Dallas, and I know you're in Collin County. Can you tell us a little bit about Cancer Support Community and the missing link that we talk about in cancer care?
I'm sure. Cancer Support Community has actually been around in the Metroplex since 2002. But what we know, although it's slowly but surely improving, is that there is fantastic medical care, medical treatment, oncology care for folks who are impacted by cancer. But the realization is really beginning to dawn on folks that if you're not inserting a psychosocial and emotional component into that continuum of cancer care, you're really not getting the best standard of care and treatment that's available for cancer. And that's kind of where Cancer Support Community fits in. Given that there are more and more, thankfully, folks who are surviving cancer and living well and living longer, what we know is that the impact of cancer does not stop at the day your doc says, you know, you're done, you're doing great, I'll see you in 6 months. What we know is actually that the level of anxiety goes through the roof at that particular moment, understandably. The question then becomes, who's got my back? Who do I go to if I've got a pain in my shoulder? Is the headache that I'm having a recurrence, or am I getting brain cancer? So Cancer Support Community comes in and we're a 501c3 nonprofit organization providing completely free of charge support to individuals, any individuals impacted by cancer, any diagnosis, men, women, and children, and regardless of where they are in that cancer, and I hate to call it a journey, but in whatever that experience is that folks are having with cancer. The other really important component is that we're there for the patient, but we're also there for those around them, their co-workers, family members, friends, whomever they come into contact with, because we know that cancer affects, in addition to the individual with a diagnosis, about 2.57 additional people are impacted by that diagnosis. So being able to offer that support for both the patient and the caregiver or loved one is absolutely vitally important to our mission. You mentioned, Steve, cancer support groups. Well, we are that, but so much more. Because our continuum of support, there are folks who may not want to go to a support group. Well, what about them? There's a huge focus on healthy living, healthy lifestyles. And so to that point, we provide things like yoga, meditation, qigong, tai chi, stability ball, light exercise. The other thing folks are craving for is really reliable, real-time information. You can go on the internet and scare yourself very badly if you start kind of delving into some of the articles and you don't really know how relevant they are, or how recent they are, or how valid they are. So bringing folks in who'll do presentations, experts in the area, whether it's a doctor, a physician, whether it's an allied healthcare provider, whether it's somebody to talk about getting through the holidays when you're living with cancer, whether it's a nutritionist, which is really popular. Bringing those folks where people can have one-on-one conversations and get their questions answered is really valuable.
Yeah, in your answer, you mentioned something that struck me. 2.57 people impacted other than the victim, including coworkers. Can you elaborate a little bit on how you help deal with coworkers in this, I know you don't like to call it journey, but in this community of caring?
Yes, it's really important because, if you just think it through logically, if you an employer out there, and regardless of whether you have an employee contingent who are heavily impacted by cancer or not, cancer is going to come into the workplace and you're going to have to deal with issues like presenteeism and absenteeism. Okay, absenteeism I think is pretty self-evident. Somebody's sick, they've got to go for treatment, they're out, etc., etc. But presenteeism is, what happens if your employee has a spouse, mother, sister, brother, sibling, whomever, or a co-worker who's dealing with cancer and doesn't know what to say or doesn't know how to support them? That's kind of where we can come in and help triage that. Even talk to management about what is the impact of cancer in the workplace and how, what are some of the things that we, cancer support community, can bring in to train you and offer information out to your employees that really helps them gain a deeper understanding of what it is that cancer does in the workplace, for example.
If people are anxious, but they need and want your help, what can they expect when they walk through those beautiful red doors you have at your organization?
Yeah, I'm smiling as you said the red doors, because I think that's such a beacon of hope. When you're in the throes of clinical treatment, it's kind of, I've got to do this, I've got to set up my next appointment, I've got to get my tests run, I've got to get my lab results back. When you walk across the threshold into one of our, as we call them, clubhouse locations, it's kind of transformative because you walk into a living room. There are armchairs, there's a social lounge or a kitchen. You'll walk up, there'll be somebody sitting at the table who will welcome you and say, hi, how's it going? How are you doing today? Are you a first-time visitor? And really kind of smooth out, if it's possible, some of that stress and angst around. It takes so much courage to acknowledge that you have a cancer diagnosis. So we know that when somebody walks across our threshold, it's kind of an immediate, let me put my arms around you without actually putting my arms around you, but create an environment that somebody says, oh, okay, I can take a deep breath here. I can slow things down. I can maybe get a handle on this.
You mentioned that you do this absolutely at no cost to the people involved. So I know, being a 501c3, you must have events to help raise money. What is one of your upcoming events?
Thank you for asking the question. Indeed, we are a 501c3 relying heavily on public support. So we have a really great event that's coming up on the 7th of March. It's called the One Run. And we say there are many cancers, but there's one run. And that's going to be at the Ron Kirk Bridge. Starting folks, again, can get information about that from our website or at oneruntexas.org. But that is a big fundraiser. More than anything, it helps raise awareness for us, and it's fun. We have a party in the park element where we invite the folks that we work with to come and have tables, distribute the information, and just actually, it's a celebration more than anything else.
For more information, the website is easy. It's cancersupporttexas.org. And again, look into the One Run on March 7th on the Ron Kirk Bridge. The website, again, has more information. And you can catch the full-length interview with Mirchelle and other guests on our podcast, The Human Side of Healthcare, on all the major popular podcast players. Next week, we're going to tackle the coronavirus outbreak. But did you know that in just the U.S., there have already been over 8,000 deaths due to the flu? Far more than coronavirus. Expert information from an infectious disease physician from Parkland. Next week on The Human Side of Healthcare.